Continuing with the series of neurology, we are going to discuss about motor neuron disease today. So to understand the terminology properly, we all know that neuron is what? It is the nerve cell, and this will be having cell body, there will be dendrites and there will be an axon. This basic all of us are knowing. Then what is motor neuron? This motor neuron is the one which is carrying motor impulses from CNS, from central nervous system like mainly brain and spinal cord to the effector cells, mainly the muscles. So these motor neurons overall are carrying motor impulses from brain to the muscle, we can say. And further they are divided into two parts, that is upper motor neuron and lower motor neuron. So how they will divide it is, when they originate in the cortex, mainly the motor cortex, they will be originating. This is the starting point we can consider. And from there, these neurons will be traveling till the nuclei of various cranial nerves in the brainstem. So this is one path we can say, that is called as cortico-bulbar tracts. Other thing will travel further down till the spinal cord. So these are called as cortico-spinal. So these two tracts are considered as upper motor neurons. Coming to the lower motor neuron, they will start from the cranial nerve nuclei in the brainstem or the anterior horn cell of the spinal cord. So these two are the starting points we can consider, and they will be relaying in the effector cells, that is mainly on the muscles. So muscles will be the end point we can say. So here muscles, and they are labeled as, if it is relaying from the cranial nerve nuclei to various musculature, they are nothing but cranial nerves. Also from anterior horn cell till the muscle, we consider them as mainly lower motor neurons, and there we can again divide them into alpha motor neurons and gamma motor neurons. So this is the division we can consider. Just to list out properly, mainly motor neurons are divided into upper motor neuron and lower motor neuron. This upper motor neuron is what? Mainly from the cortex, motor cortex, till two things, either the cranial nerve nuclei or spinal cord. So this is called as cortico-bulbar, and these are called as cortico-spinal. They are all upper motor neurons. Lower motor neurons will originate from the nuclei of cranial nerves, so nuclei of cranial nerves or the anterior horn cell in the spinal cord, and till the effector cells, that is till the muscles, they will be taking care of. And we know that these upper motor neurons are not in direct contact with the effector cells. They are just relaying with the lower motor neurons. But the one which is in direct contact and having maximum impact is lower motor neuron. And this UMN will be controlling LMN in the inhibitory pattern. So this is also important. And finally, when we divide alpha motor neuron or gamma motor neurons, what is the function? These are mainly for the muscle contraction, we can say, whereas gamma motor neuron is helpful for maintaining the tone. So this basic we have to know before considering the disease related to motor neurons. So now it might involve corticospinal tract, corticobulbar tracts, or the lower motor neurons as well. That we are going to discuss in detail. Now whenever there is upper motor neuron issues, that is corticobulbar and corticospinal tracts will be controlling lower motor neurons in an inhibitory pattern. So when there is damage to the upper motor neurons, commonly because of stroke or demyelination and all, there might be damage to upper motor neurons. So this inhibitory control will be lost, leading to hyperexcitability of both alpha and gamma motor neurons, manifesting as increased tone because of excessive activity in the gamma motor neurons. That might manifest as stiffness or spasticity. And when it comes to the complaints, patient might themselves tell it as stiff feeling. And if you examine, reflexes and all will be exaggerated. So this is another manifestation we can say. And suppose it is the involvement of corticobulbar tracts, the bulbar region manifestations will be considered as pseudo-bulbar signs, because 9, 10, 11, 12 cranial nerves are there in the medulla, which we call as bulbar. And now we are saying that upper motor neuron, which is what? The part which is starting from cortex till the level of cranial nerves, is injured. That's why it is called as pseudo-bulbar. Suppose if there is involvement of the cranial nerves or their nuclei, that is LMN type, that is called as bulbar involvement, whereas the UMN is called as pseudo-bulbar involvement. So how does it manifest? There might be dysarthria, mainly spastic type of dysarthria or choking sensation in the throat, or there might be emotional lability. These are the manifestations. Whereas lower motor neurons, the one which is starting from anterior horn cell or cranial nerve nuclei till the effector cells, that is muscle, is called as LMN. Suppose it is having some injury, that is LMN disease, commonly seen in anterior horn cell disorders or peripheral neuropathies or neuromuscular junction problems, even muscle disorders. There might be LMN disease manifestations. So the direct contact to the muscle is lost, leading to flaccidity, hypotonia, and the reflexes will not be elicitable, as well as we will be able to see wasting of muscle, atrophy, and there will be fasciculations. These are all the hallmark feature of LMN diseases. And if there is involvement of bulbar region, it might manifest as difficulty in chewing, swallowing, or movement of tongue difficulty, or there might be abnormality in the facial muscles. So these are all manifestations of LMN disease. So hope you got a clear picture regarding what is upper motor neuron and what is lower motor neuron, and what will be the manifestations when there is disease in these particular segments. After understanding these basics, we will discuss about motor neuron disease. So it might manifest as purely upper motor neuron disorders or purely lower motor neuron disorders. Also, there might be a mixed pattern. So here, if you remember, mainly it will involve cortico-bulbar tracts or cortico-spinal tracts, and it might manifest as spasticity, exaggerated reflexes, spastic dysarthria, or choking sensation in the throat. So these are some common presentations, and usually as it is not in direct contact with the muscles, we will not see much evident wasting or atrophy or fasciculations in upper motor neurons, which are very common in lower motor neuron disease. So what are the examples? Suppose it is involving corticospinal tract only. As we know, it is again divided into lateral and anterior corticospinal tracts, right? So because of this particular tract involvement, it is named as primary lateral sclerosis. Then we have to remember about the pseudobulbar palsy, where it is involving corticobulbar tracts. And another pure UMN type of disorder is hereditary spastic paraplegia. When it comes to pure LMN type, if it is in the spinal cord region, it might manifest as spinal muscular atrophy. If it is in the bulbar region, it might manifest as bulbar palsy. The other pure LMN disorders, just to enlist, are Kennedy disease and adult Tay-Sachs disease. Whereas when it comes to mixed pattern, that is both upper motor neurons and lower motor neurons, both are involved. Now the terminology will combine. That is, there is lateral sclerosis from this particular side, and there is amyotrophy from the lower motor neuron type. That's why it is called as amyotrophic lateral sclerosis, and it is one of the classical disorder when it comes to motor neuron disease. That's why we are going to discuss it in detail. So what will be the pathophysiology of amyotrophic lateral sclerosis? It is mainly considered as a degenerative condition. If you remember from last few lectures, the other neurological degenerative conditions, just to enlist, there was Alzheimer's dementia, Alzheimer's disease, frontotemporal dementia, Huntington's chorea. So these were few degenerative conditions. Similarly, in motor neuron disease, ALS is considered as a degenerative condition. So what happens is, there will be some genetic mutations in SOD1 or TDP43 gene, FUS or TLS genes. These are some genes where mutations will happen, leading to formation of abnormal proteins, and they will start getting accumulated in the neurons. So what are these abnormal accumulations? Mainly ubiquitin, TDP43, cytoskeletal protein, and lipofuscin. So these are all getting accumulated, and these are toxic products, we can say, which will be damaging the neurons. So how they will damage is, they will ignite immune reaction, or else they might just make the neuron hyper excitatory. So excitation will increase oxidative stress. So these mechanisms will lead to neuronal death. But what are the mechanisms involved when it is mainly due to immune reaction? There will be widespread inflammation, proliferation of microglial cells, finally leading to terminal gliosis, a form of sclerosis. That's why the name lateral sclerosis. The motor neurons in the corticospinal, that is lateral corticospinal tract, commonly is getting sclerosed at the end, overall resulting in the neuronal deaths, and preferably these neurons are motor neurons of both upper motor neurons and lower motor neurons. So when lower motor neuron is damaged, obviously there will be no tropical stimulation to the muscle, leading to its atrophy. That's why the other term amyotrophy. That's what is explained in this one. Just to understand the disease terminology better, amyotrophy, that is the neuronal LMN type of neuronal loss, leads to direct denervation resulting in severe muscle wasting and atrophy. That's why myo means muscle, trophy means some problem with the nourishment. That's why they will go wasted. Lateral sclerosis, you have understood now. Because of the UMN effect, there will be immune reaction like microglial proliferation and inflammation, leading to reactive gliosis, mainly in the lateral corticospinal tract, which make them hardened and scarred. That's why the term sclerosis. Hope you have understood it better. So once this pathogenesis has started, there will be continuous degeneration over a long period of time of upper motor and lower motor neurons. And if you remember, some of the gene mutations like TDP43 are also involved in the pathogenesis of some other disorders like frontotemporal dementia. So you might see dementia manifestation as well in the same individual. But here there is a trick. Whatever accumulation and degeneration of motor neurons is happening, this pathophysiology will spare some of the structures in our body. So whenever there is suspicion of amyotrophic lateral sclerosis, usually the following structures are spared. It will not involve sensory functions. It will not involve cognition unless it is associated with frontotemporal dementia. It will not involve ocular motility, and there will not be any manifestations related to bowel and bladder functions. So these things you have to remember. Particularly when it comes to bowel bladder involvement, there is a specific structure called as nucleus of Onuf, which has very high concentration of parasympathetic neurons, which will innervate the sphincters, are highly protected from this degenerative process. That's why there is no manifestation of bowel and bladder dysfunction. So whenever you get a case of motor neuron disease, you will be looking for upper motor neuron manifestations and lower motor neuron manifestations. But also it is important to look for the sparing of these particular things, mainly eyes related things, sensory, bladder and cognition. And with this cognitive sparing, we can remember famous scientist Stephen Hawking, who had ALS disorder. And obviously, we all know that there was sparing of cognition in him. Now, when it comes to ALS diagnosis, remember that it is a fatal neurodegenerative condition. Once you label an individual as having motor neuron disease, particularly ALS, it will be fatal with the median survival of just 3 to 5 years. So, before labeling, you have to be very careful and you have to rule out all the differential possibilities. So according to World Federation of Neurology, even for thinking ALS diagnosis, it has to meet some of the criteria like simultaneous involvement of both upper motor neurons and lower motor neurons should be there, and there should be a history of progressive clinical weakness with exclusion of all the alternative diagnoses. So what are those alternative diagnoses which we have to consider before labeling it as motor neuron disease or ALS? Mainly some benign conditions like benign cramp fasciculation syndrome. So as mentioned, due to lower motor neuron involvement, we will be able to see fasciculations, but there will be associated weakness in that. Whereas in this benign condition, there might be fasciculations without any weakness or atrophy. So just the presence of fasciculations will not label the condition as having motor neuron disease. You have to look for weakness or atrophy. Or the motor manifestations might be just due to some toxic compounds like lead poisoning or thyrotoxicosis. Also, the motor neurons might be involved because of multifocal motor neuropathy, which is an autoimmune condition with conduction blocks. So in that case, we have to check for autoantibodies, particularly to GM1 ganglioside, because it is treatable with immunosuppressive therapy or IVIG. Similarly, when you find motor abnormalities of upper limb, lower limb and all, always try to think of cervical spinal cord compression or cervicomedullary tumors, because again, these tumors or compressions are considered as treatable conditions. Or there might be other differential possibility, that is motor neuronal conduction block. So there is no actual degeneration in the motor neuron, but the conduction is getting delayed. That might be manifesting as motor abnormality. So it has to be confirmed using electrophysiological testing, in which we will be able to see decreased speed, that is conduction, but there is no actual neuronal loss. So after ruling out all of these, we can consider the possibility of ALS. And for that, World Federation of Neurology has given some criteria. That is, we have to check at 4 distinct anatomical regions. For example, bulbar involvement in the form of chewing difficulty, swallowing difficulty, facial movement problems or tongue movements issues, even dysarthria and all. When it comes to cervical region involvement, it might manifest as motor abnormalities of upper limbs. It might be UMN type or LMN type. Also, in thoracic region, same motor issues are related to mainly chest muscles or back muscles and all. So you might be able to see prominent wasting, atrophy of these musculature, or there might be difficulty in breathing and all. So mainly chest, abdominal, back muscles are involved. In lumbosacral region, it might manifest as the motor issues, motor problems in lower limbs. So entire head to toe examination is required to look for these 4 distinct anatomical regions. And to consider ALS, we can say it as possible case of ALS when there is clinical evidence of UMN, LMN, but only in one anatomical site. Suppose 2 separate anatomical sites are involved, for example bulbar plus lower limb, or cervical plus thoracic, cervical or lumbar, we call it as a probable case of ALS. Suppose there is involvement of 3 or 4 anatomical sites, then we might label it as a case of definite ALS. And whenever there is proven genetic mutation of superoxide dismutase 1 gene, even if only one site is involved, that will directly confirm the case as definite ALS case. So the genetic study is a very strong diagnostic marker. How to treat now? Mainly it is a degenerative condition. That's why we say currently there is no curative treatment for ALS. But still, there are some medications we can utilize. For example, riluzole, which will act as a synaptic blocker. So what it will do? It will decrease the glutamate release, limiting neurotoxic excitability. So the oxidative stress will come down. So the functional lengthening of patient survival will be improved to some extent. The dose is 100 mg per day. Other drug is called as edaravone. It will act as a neuroprotective shield. Mainly through its powerful antioxidant effect, it will help to some extent in the prevention of neuronal damage. This was in detail regarding amyotrophic lateral sclerosis. The other motor neuron diseases, mainly purely element type. The example is spinal muscular atrophy. So there are various types, we can say infantile onset or chronic childhood SMA variant or juvenile variant. So definitely type 1 will be having most severe presentation with very less survival, typically resulting in mortality within 1 year of life. Whereas childhood onset type 2 SMA is having intermediate severity and juvenile SMA is quite later onset. In all of these, we will be able to see element type of manifestations, mainly in the proximal muscles of upper limb or lower limb. Commonly it will involve lower limb. And for this, the main pathology is again genetic mutations in SMN protein, leading to irreversible neuronal loss. But it has preferential involvement of lower motor neurons. And for this genetic mutation, there is gene therapy option available, which will restore the SMN protein. Example is Zolgensma. Again here, the manifestations you have to enlist as the features of LMN disease like flaccidity, hyporeflexia, evident wasting, atrophy, fasciculations and all. So all these things will be applied, but as it is not much common in adults, we are not discussing it in detail. Similarly, when it comes to pure UMN type, there is a condition called as hereditary spastic paraplegia, that is HSP. So the primary deficit is preferentially involving the upper motor neurons, leading to spastic type of paraparesis. So mainly we will be able to see UMN features involving lower limbs preferentially. But there is some exceptional feature when it comes to HSP, that is it might extend to involve beyond pure motor tracts. So it might also involve posterior column, leading to impairment of vibration and joint position sense. And the one which was maximally protected, the nucleus of Onuf, might also get involved in HSP, leading to bowel bladder dysfunction. This was the chapter summary from Harrison textbook regarding motor neuron disorders. So whenever you see a case which is having both UMN and LMN type of features, particularly asymmetric manifestations with prominent wasting, atrophy, fasciculations and all, think of motor neuron diseases and try to look for the structures which will be commonly spared: sensory, bladder, cognition, oculomotor parts. So these structures are particularly spared. That is again a strong clue towards motor neuron diseases. But before labeling it as motor neuron disease, always rule out the close differentials which we have enlisted, because it is a fatal neurodegenerative conditions. No much curative therapy is available, but we can try with some of the antioxidant medications. Thank you so much.